Welcome to this session, which examines the relationship between food and health system. My name is Nogokanya Mwabe, and I will be sharing a presentation compiled for us by Dr. Wanga Zembe Mkabile of the Medical Research Council in South Africa. So why is it important to consider or even acknowledge the relationship between food and health systems in African cities? Well, health is a proxy for general well-being, which means whether and how a city takes care of its residents' health is a key measure of that city's livability. It's important then to understand that there is an interrelationship between health and food. How so? Well, people who enjoy generally good health and reliable access to healthcare conform in the broadest sense to the World Health Organization's conception of well-being, which extends beyond the physical absence of illness. Health implies, in part, that a person is eating well. In other words, that they not only have access to food, but that that food is nutritious, that they can afford to acquire adequate portions to nourish and sustain themselves and their families. This is the first and most self-evident relationship between health and food. But it's also important to consider a person's living conditions, because whether food is prepared and how it is prepared is equally important. And so we should consider, are there appropriate sanitary conditions to avert the contamination of the food? Is water accessible to clean the space? Is safe cooking equipment and clean energy readily and affordably available to the person who is preparing said food? So we start to see that health is actually a proxy for so many different structural things. And if any of these are compromised, there is an immediately discernible impact on food, as well as a knock-on effect on human health. And so if we consider, for example, a person whose living conditions are subpar, it's far more difficult for that person to prepare food in a sanitary environment. Similarly, if people don't have adequate resources, they will not be able to acquire food that is of a good standard. They won't be able to ensure dietary diversity. They won't be able to buy the quantities that are needed to meet their nutritional needs, which will make their food intake lower than professionally recommended standards. And in such circumstances, a person is at risk of presenting with poor health outcomes, such as malnutrition or undernutrition. These conditions that we've described affect children even more negatively. Limited access to nutritious food puts children at risk of stunting, which in simple terms is the failure to meet their physical and cognitive developmental milestones. But stunting is an indicator of many other life outcomes. So, for example, a child lacking that cognitive development will have poor educational outcomes, which restricts the economic and livelihood opportunities available to them when they are adults. And another contributory risk factor of stunting, worryingly, is child mortality. So we see that physically, stunting is discerned in children who fall significantly short of the height indicated for and visible in their better nourished peers. Children with stunting generally impose a greater burden on the healthcare system than other children. They require more regular and frequent healthcare access. Further, if the healthcare system doesn't function optimally, then children with stunting face an even steeper challenge, which is why Dr. Wanga Zembe pointed out to us that it is important to consider whether and how well a city takes care of its residents, both in terms of their access to food as well as their access to healthcare, which influences not only the quality of life they're able to enjoy, but also the life outcomes that they're able to attain. It's important for us to think about the lessons that COVID has provided us about access to food. So the COVID-19 pandemic had a devastating impact on the informal economies of most African cities, but it presented a unique opportunity to assess the immediate and compounded effect of compromised access to food in a larger population of city residents than was customary prior to the onset of the pandemic. The links between food and health that public scholars have been touting was suddenly discernible even to the ordinary person. who could quite viscerally appreciate that social determinants of health are as important for human well-being as epidemiological ones. Thus, while policymakers' initial focus after the onset of the pandemic was disproportionately on the physical, often life and death implications of COVID-19, the focus soon turned to the socioeconomic implications of the hard lockdown. The hard lockdown speaks to the pandemic containment measures that were introduced by the South African government, which confined people to their residences, with access to public spaces restricted to healthcare and emergency personnel. People were required to socially distance, which means that they were required to ensure that they kept a stipulated distance away from each other. And this was a feat that proved virtually impossible in informal and slum neighborhoods where households are made up of many people living together in very tight-knit quarters. The lockdown measures even included abstinence from smoking and drinking while these regulations were in place. And of course, this led to tremendous frustrations on the part of South Africans. But it's important to consider that lockdown measures also prohibited informal traders from pursuing income-generating opportunities. And since the majority of such traders did not have massive savings or investments to draw down on, their earnings were quickly depleted, and they were unable to replenish this through their usual activities, which left informal traders with very limited recourse to food and other necessities. Not only was this a bread and butter survival issue, but it soon became evident that it was also a mental health priority, with people taking tremendous strain and under increasing strain to meet their livelihood needs. The lower income participants, who included many mothers, who were interviewed by Dr. Wangazembe Mkhabile, some of whom had participated in studies conducted by the Medical Research Council over several years, highlighted the precarity of their lives, even during so-called normal times. And they emphasized the extent to which COVID-19 had exacerbated this. They described a hand-to-mouth existence, which was characterized by trade-offs between food for the family on the one hand and meeting other priorities such as the purchase of cooking fuel, for example, paraffin or electricity or charcoal, the purchase of airtime, the cost of transportation to access healthcare facilities or retail stores offering more affordable and varied food options, etc. The onset of COVID-19 brought the strategic day-to-day pursuit of enough food to a crisis point very swiftly. Thus, for example, none of Dr. Zembe Mkhabile's participants, who were part of a 500-plus cohort tracked for over 6 years, reported contracting COVID-19. None reported detecting symptoms of COVID or reported to hospital for fear that they were infected. And yet, COVID immediately affected them through the loss of jobs, both formal and informal, which they relied on to stretch the small government grants that they accessed, oftentimes for their children or for the elderly members of the family. Many of these mothers recounted how even the reciprocal social networks that they had previously relied on to stretch their grants and to plug gaps quickly dissipated as a result of most people being out of work. Those who did retain jobs tended to prioritize their own needs. And these mothers described this as people shortening their hands because they weren't certain of repayment and they wanted to prioritize their own or their family's situation. And so the COVID-19 pandemic introduced a crisis point almost immediately. Children had to stay at home and not go to school, which is where many of them would access school feeding schemes, which provided 2 meals in many instances. These children were now stuck at home. Their caregivers, who'd been used to only making provision for 1 meal, now had to find a means to stretch that 1 meal to 3 in the midst of a pandemic in which their jobs were taken away. Their grants had to stretch amongst a greater number of people within the home. And they were all squeezed into tight confines where the children became frustrated, they couldn't go out and play. And so we see this relationship between the crisis to secure food on the one hand, to manage the household on the other, to contend with the stress and the pressures of making this provision, to see to the children who are out of school and who have an expectation of returning, having covered some of the syllabus. All of this falling onto the shoulders of those who are the caregivers within the home. And so we see that interrelationship between the food and the nutritional needs, the mental health concerns, the physical epidemiological concerns of the pandemic itself, and the social frustrations that this confinement bred. And so the line that cuts across those tells us that these cannot be understood in isolation, but really should be examined together to get the full and holistic picture of what it means for a city to avail food on the one hand, which sees and contributes to the well-being of its residents on the other. Thank you.